On to our final formal session of the day before we go into our wrap up and then breakout sessions. We're going to have a quick research update and Q&A. So our speakers are Professor John Grigg. He's the head of clinical ophthalmology and eye health at University of Sydney. He's a group leader of eye genetics research unit at the SSI Institute, and his research interests in that area include genetic eye disease, glaucoma, and electrophysiology of the visual system. Professor Robin Janison is the head of genetic medicine and professor of genomic medicine at University of Sydney. She leads the eye genetics research unit at the Children's Medical Research Institute, the Children's Hospital at Westmead, SafeSight Institute, and the University of Sydney. And she heads the Western Sydney Genetics Program. Dr. Sophia Zagora is a consultant ophthalmologist at the Sydney Eye Hospital and the Children's Hospital Westmead. She specialises in uveitis, medical retina, and complex surgical treatments of the above. She's heavily involved in clinical research and a senior lecturer at University of Sydney. And finally, Professor Stephanie Watson is the ophthalmic surgeon specialising in cataract, corneal, and laser surgery with expertise in eye disease. She's known for her groundbreaking research in stem cell treatment for corneas, and she's been featured in ABC's New Inventors and ABC's Catalyst programs. I'm going to stop tripping over words and hand over to you all. Thank you for joining us.
Thanks very much, Michael. I thought we'd probably all give a couple of minute updates of what's been happening, and maybe we could start with Robin. Could start where we are with the genetic eye.
Thanks, John. It's a pleasure to be here, everyone, and it'd be nice to be seeing you face to face, but I guess this is the world in which we live now. Certainly been a really inspiring day, some fantastic speakers and loads of really good practical tips, I think. So I just wanted to give you an update on where things are up to with genetic eye disease, particularly from the retinal disease space. There is certainly a lot happening there in terms of therapies. In fact, the first ocular gene therapy has now been approved by the Therapeutic Goods Association in Australia, and that's for the therapy for one of the severe forms of retinitis pigmentosa called, sometimes called Leber's congenital amaurosis, due to mutations in the RPE65 gene. So there's not many patients in Australia affected with mutations in that gene, but we think it's groundbreaking because it's the first, and the first that's been approved in Australia. So we're very excited that it's likely that therapy first will be conducted in New South Wales, and that we've been working with the New South Wales government, who's working towards having New South Wales as a centre for these types of therapies. So I think the space is good for moving ahead, and there's also plenty of opportunities in other areas. For instance, the corneal area for potential, not only the stem cell approaches that Stephanie's involved in, but also genetic therapy approaches there. So from a research perspective, there's lots happening in the retinal space and that space as well. And just as a practical element, I guess, because these approaches are coming for people who do have genetic eye diseases, there are resources available for genetic testing across the state, and there is a website that you can go to through the Genetics Education Australia that will let you know where your nearest genetic service is, so that you can ask for a referral from your general practitioner or your ophthalmologist to the genetic service, so that you can get that organised, because there are other trials and so on happening that John will mention, and so it's really important to have your ophthalmic information, obviously, in terms of how your disease is progressing, but also the genetic information as well. And I'll put that on the post so that you can see that website to go and find those services, if that would be helpful for you. So
thanks, Robin.
Thanks, John.
Yeah, thanks. And now get an update from Stephanie. Thanks, Stephanie.
Thanks, John. So I head the corneal research group, and look, it's been an exciting year. We've progressed our stem cell treatments towards the clinic. We're now looking at the GMP facilities where we can do it. These are special facilities that enable us to keep everything to the highest standard for when we go into a clinical trial. For our registry program, this program collects all the data that normally just sits in doctors' notes. And from that data, we find out which treatments are best. And we've also included in that a questionnaire so we can find out what patients actually think and what they want from their treatments. And our keratoconus registry now has over 25,000 patient visits on it, and we've gone international. We're about to release a dry eye registry. With dry eye, one of the commonest reasons for patients to visit an eye specialist, we think that will be very popular. Now, corneal infection around the world is still causing many people to lose sight. And our recent studies have shown that it can occur in people with other ocular conditions. And the treatment still relies on clinicians giving sort of general types of eye drops. And what we've done is the first surveillance report for keratitis showing which bugs actually cause the infection, so we know which antibiotics to give them. And we're hoping that this will help to save sight and prevent loss from corneal infection. Thank you.
Thanks, Stephanie. Now, Sophia, would you like to provide an update as well?
Hi, my name is Dr. Sophia Zagora, and I subspecialise in uveitis and paediatric uveitis. We've been busy at the Children's Hospital at Westmead. We've started a joint clinic with a paediatric rheumatologist. So we're starting to see more patients together. We're co-managing our patients on biologics and also other immunosuppression. We have quite a large cohort on biologics and now also JAK inhibitors. We are looking to also start a trial, an international trial run out of the NEI, looking at actually stopping immunosuppression in patients who are quiet. So looking at Humira, which has been one of our most successful biologics in children who have been quiet for over a year, we're going to start enrolling patients to then look at how we're going to stop that drug.
Thanks, Sophia. And to sort of conclude the updates, sort of where we've gone with particularly inherited retinal disease in the last 12 months, we've now actually commenced clinical trials with part of international studies. And so we started enrolling in the first one 6 weeks ago for Usher syndrome. This is for adults, but we've also been selected as a site for Stargardt disease through the Children's Hospital at Westmead for people with Stargardt who are diagnosed under the age of 18. And so will start probably either the end of this year or the start of next year. And so, as Robin highlighted, understanding the genetics of your own individual condition is really critical so that you can then sort of become involved in these trials, which are leading to therapies. So the therapies at this stage will probably slow the progression or halt the progression of the disease. And then maybe as we go further, provide opportunity to try and regain vision. The other area that we've been working on is the health economics, which sort of helps tie the whole program together. And the health economics provides information to governments to help fund these therapies when they come, because these therapies are very expensive. There's an opportunity to contact the team through the Children's Hospital at Westmead or the Stabilization Institute to enroll in this. This is for people with retinal dystrophies is the first instance. So that sort of provides an update of where we've gone over this year. It's been quite a lot of things have happened despite COVID. So we're now happy to take questions from people who, as they come through, and perhaps we'll see if any are on the chat. We've got,
I can see that we've got some questions around patching. Does the latest research back patching or drops for children, please?
That's a pediatric question, and that's a good question to remind us that despite underlying conditions, it's important to remember the basics of making sure the glasses are the correct glasses. That's really important, and then trying to equalize vision. And so patching is a way of trying to equalize the visual development, because visual development requires equal inputs from each eye till about the age of 8. And so patching is really a dosage thing. So we have to get a number of hours up over that time in the critical visual development period. There's been a number of studies now from the International Pediatric Eye Disease Investigation Group, or PEDIG, which has shown that looked at these questions about patching, which is a physical patch across the eye, or using atropine eye drops to blur the eye. And these are equivalent for many types. So it depends on the particular situation of the person as to which one would be better or preferred. And they can be interchanged in many situations. But patching children in that toddler age is often a challenge. And so that's where the atropine drops have been helpful. But it does depend on the cause for the vision equality as well.
So thumbs up for patching.
Critically important.
Another question we've got, I have a student involved in a Stargardt study, I think that's that wrong, and would be interested to hear if, anything about that study.
The Stargardt study is using a medication to alter the delivery of one of the important components of the visual cycle to the eye. Stargardt disease is a condition where the transport of one of these agents is blocked, and it leads to an accumulation of material that's toxic to the cell. So by trying to alter another pathway, it may prevent the accumulation of the toxic material and then help stop the degeneration of the retina. So it's an oral tablet that's going to be taken. It's a phase 1 trial, so it's very early in the process, and it needs sort of the complex and sophisticated clinical trials set up they have at the Children's Hospital, because there's some blood tests to monitor the process and multiple eye tests as well. But if you have people who are interested in that age group, then we'd certainly be interested to hear from you.
Fantastic. Another question, are there any developments in the treatment or stabilization of cone rod dystrophy?
Robin, do you want to answer that?
So as we mentioned, there is certainly progress happening in the clinical trial space and the therapy space. So I think it's a bit tricky. I think it's important to realise that now that we move into this era of genetic therapies, that we do have to specify the type of cone or cone rod or rod cone dystrophy that the person has, because certainly there, for some of the cone dysfunctions, there are clinical trials happening internationally, but we do have to know what the genetic cause is to be able to be part of a clinical trial or indeed a therapy at the moment. So I think it's slightly hard to answer that question completely generically. I think there's a lot of action, but to answer specifically, we kind of need to know which gene there is. Certainly, my research group actually has a research program looking at, there are now thought to be inflammatory contributions to some of these retinal dystrophies. And we've recently discovered a novel disease gene that will be giving us an insight to that, I think. And so we're working at the scientific level at the moment to understand that in more detail. But that certainly is something that, if we think about these cone or cone rod or rod cone dystrophies more generically, then that may be a therapy that can give some treatment for the whole group. So yeah, I hope that helps answer that question.
Fantastic. And I'm going to throw one last question in myself, because I've noticed in a number of what you've said, you've talked about trials. You came up earlier, and in the media this year, we've heard of nothing but phase 1, phase 2, and phase 3 trials. So maybe it's an opportunity to say, what is the difference between the phases of a trial?
Stephanie, do you want to?
Yeah, sure. So phase 1 trial is really just sort of getting your pilot data. So it's very expensive to do a clinical trial, and sometimes there might be safety issues. And so you just need to sort of show that the drug kind of goes okay in people. And then as you move through the phases, you're getting into sort of more rigorous trials with larger numbers of people, because you're confident that that the drug is safe. And then you're sort of looking for the effect of the drug through the, and regulatory agencies such as the TGA, who say, look, this can be a medicine, be given to people in Australia, have a want to see phase 3 clinical trial data. So it's involved in showing that the drug works, that it's safe, and also in getting it regulated depending on what phase you're in.
Fantastic. I think we've covered our questions for the day. I think that was a great update on the research. So let's close out our research update. And at this stage, we get up to John's final words for everybody.
Look, I'd like to take the opportunity to thank everybody who contributed today. It's been a really fantastic update. And before I go through the individuals in particular, I just sort of, some of the themes that I took away from this was that I think we've learned to be able to advocate for, as clinicians, for our patients, but also the individuals have to advocate for themselves in obtaining the services, helping with the education. I think resilience is another theme that's been really highlighted through our guest speakers today. And also perhaps trying to find a niche in which you can sort of have a little bit of success, which helps take you along and build on that resilience. I think our panelists and our experts and invited guest speakers have really been showing a lot of honesty and candor in their discussion about